Hi everyone, and thank you for joining us for today's webinar titled Ahead of the Curve, Radiology Practice as a Catalyst for System-Wide Clinical Decision Support. We are pleased to bring you this webinar in partnership with the American College of Radiology. Today's webinar will be moderated by Dr. Christie Lincoln. Dr. Lincoln is an assistant professor of neuroradiology at Baylor College of Medicine and chair of the ACR PAMA implementation workgroup. With that, I will turn today's call over to Dr. Lincoln.
Thank you, Kristen. The goal of Imaging 3.0 is to provide optimal imaging in patient care. Many healthcare systems around the United States are already participating in value-based imaging care or taking steps to get there. The goal of this webinar is to provide practical guidance in beneficial and necessary imaging care delivery. We've been developing a transition model that breaks down what needs to occur in three key areas. Changing the culture of radiologists in terms of how they interact with referring physicians and patients. Adopting new tools in optimizing imaging and patient care delivery. And lastly, alignment of incentives to support these changes. There are a number of changes we'll see in the Imaging 3.0 era. We'll move to a value-based model from a volume-based one. Radiologists will return to a consultative relationship from transactional ones. We'll move to a patient-centric model from a radiologist-centric one. Radiologists will transition to a focus on patient outcomes from image interpretation. Radiologists will become integral to the provision of care and no longer be regarded as commodities. And when we do all of this, radiologists will become an accountable member of the healthcare delivery team. So now we'll begin polling with a question before we begin today's session. How many audience members work in a facility that has implemented clinical decision support? A, my facility has clinical decision support software implemented in its electronic health record. My facility doesn't currently utilize clinical decision support, but we're considering investing in the technology. C, my facility has no plans to implement clinical decision support software. Or D, the question is not applicable to my situation. Okay, so it looks like we have a pretty good spread of people who are, most everyone is considering investing in the technology, but there's an equal spread between those who've already implemented and those who have no, it's not applicable. Okay, so we'll move on to the speakers. So a key tenet of Imaging 3.0 is that in order to demonstrate value during the entire imaging care process with a measurable impact on outcomes, radiologists need to take a leadership role in shaping America's future healthcare system. This webinar will showcase how radiology leaders at MD Anderson Cancer Center in Houston partnered across departments to integrate clinical decision support into their healthcare system medical record and to put referrers on the pathway to protecting access to Medicare Act compliance. Now I'd like to turn the presentation over to Dr. Melissa Chen, who is Assistant Professor of Neuroradiology at the University of Texas MD Anderson Cancer Center in Houston. Dr. Chen is also the Relative Value Scale Uptake Committee, or RUC, advisor for the American Society of Neuroradiology, and she is also chair of the Economics Committee for the American College of Radiology's Commission on Patient and Family-Centered Care. Dr. Chen will provide an overview of clinical decision support and how it relates to PAMA legislation. Dr. Chen?
Thank you for that introduction, Dr. Lincoln. In addition to assisting in the CDS implementation effort at MD Anderson, I'm also a member of the ACR's PAMA implementation workgroup that's chaired by Dr. Lincoln, and I am excited to be speaking with you today on this topic. So to give you just a brief overview of our healthcare system, MD Anderson is an integrated multidisciplinary cancer center. We currently treat over 140,000 patients a year, and we are a growing national network. We do have trainees within our system. We have residents and fellows that train at our institution. And although we are a large academic medical center, we hope that there are some lessons that we've learned that could be scaled to different practice types. So to start off, what is clinical decision support? It is, for radiology, a functionality in the health information technology where appropriateness use criteria is developed by a multidisciplinary group of physicians based on best evidence available, expert consensus, and used in conjunction with the patient-specific information to make recommendations of the best imaging study available or potentially to recommend no imaging to be performed. And the goal is to reduce inappropriate imaging of studies. And this is based on the legislation Protecting Access to Medicare Act. And just to give a brief overview of what this legislation requires, it requires consultation of clinical decision support for advanced imaging, which includes CT, MR, and PET imaging, as well as other nuclear medicine studies. And this consultation has to occur at the time that the order is placed by a licensed provider or one of his or her clinical staff acting under his or her direction. And the reason for this language is so that, for example, clinical staff being someone such as a nurse who's working under the supervision of a physician could assist with the consultation of clinical decision support, but not someone like a front desk receptionist who may not have clinical knowledge or background to be able to order the study. This must occur in studies ordered from physicians' offices in an outpatient hospital department, including the emergency department, the ambulatory surgical center, or an independent diagnostic testing facility. Now, there are some exceptions, and they're listed here. Most emergent cases as defined under EMTALA are excluded. Inpatient studies, inpatient exams are also excluded as they are part of Medicare Part A payment. But remember that there may be patients in your hospital, like in a clinical observation unit for 24 hours, that may still be considered outpatients, in which they would still need to consult the clinical decision support mechanism. And then there are some exceptions for physicians who have limited access to internet, or if there's some issues with vendors. The CMS has defined defined parameters for what qualifies as a qualified clinical decision support mechanism, but one of the main things that it needs to do is cover some priority clinical areas and have reasonable coverage of these areas. And so listed below on this slide is kind of showing you the different clinical areas that must sort of have coverage by the clinical decision support software. Now, I know all of you are probably thinking that this is a huge administrative burden and cost, but this is something that is necessary in the face of increasing healthcare costs, and in particular imaging. I know that at our institution, we actually have a lot of administrative costs associated with seeking prior authorization for patients, and this includes both physician time as well as our administrative staff, calling back insurance companies to get authorization. And then there is a thought that potentially this could circumvent some of that by having implementation of clinical decision support. So hopefully this is something that we can utilize for the future. This also would potentially alleviate some of the anxiety that patients have with waiting for studies to receive authorization and also delaying their care. I wanted to go over a brief history of how we got here so that we can take a step back to understand what was the impetus towards implementation of a program such as this, and hopefully see this as an opportunity that we can improve care and really take part in improving in the way that we deliver care to our patients. So in 1993, Bill Clinton was elected as president, and one of the first things that he did was created the Healthcare Task Force, which was chaired by Hillary Clinton. And it was during this time that K.K. Wallace, who at the time was the chair of the Board of Chancellors for the American College of Radiology, testified before the House Ways and Means Committee, pledging that radiology would take a leadership role in defining the most cost-effective and beneficial ways of utilizing radiology services. He acknowledged that potentially some of the focus may be related to inappropriate utilization of imaging, and he said that radiology stood ready to design a system of patient care guidelines to eliminate inappropriate utilization. And from this initial statement was born the Appropriateness Use Criteria Task Force that the ACR started, and from there many other appropriateness use criteria were created. Unfortunately, in the last 2 decades, as we have seen, imaging utilization increased. There was increasing focus on the utilization of imaging as a driver of healthcare costs, and this study was by the New England Journal of Medicine in 2009. And you can see here in the top line where imaging far outpaces other services, including E&M services provided by primary care providers, for example, which is the bottom line. And as a result of this, unfortunately, imaging saw over 12 payment cuts over the last over those 6 years. A lot of this was to the technical component, but it did affect radiologists as well. And the discussion about decreasing imaging utilization really did center around cutting reimbursements or implementing radiology benefits manager. And it was during this time that as well that the Agency for Healthcare Research and Quality developed guidelines for appropriateness use criteria processes where there would be combination of both evidence, expert consensus, and input from physicians of multiple medical specialties to come up with these criteria. And then we saw the signing of the Affordable Care Act in 2010. And this was probably one of the most significant legislation since Medicare was founded. And unfortunately, radiology was a significant target within this piece of legislation. And if not before the multiple rounds of cuts to reimbursement that radiology experienced, now more than ever did the radiology community recognize really the need to be a part of the solution rather than stand by and wait for changes to occur. So in 2014, Congress passed PAMA, which included the mandate for consulting appropriateness use criteria. And it's important to note that no one in medical specialty societies opposed PAMA, and it was the first time that Congress was able to keep radiology benefits managers out of Medicare. And remember, this piece of legislation prevented was the last SGR fix, and it prevented 24% reduction in physician reimbursement. And so this was sort of a way to reframe the discussion around radiologists being at fault for overutilization of imaging, but really showing that radiologists wanted to be a part of the solution. And so I alluded to this before, that potentially the implementation of clinical decision support could circumvent the RBM process that we have come to know. And here is outlined in this diagram of the multiple different iterations that physicians and administrative staff need to go through in order to seek approval for imaging studies for patients. So this is the latest implementation schedule based on the proposed or the final rules of CMS from 2019. Currently, we are in the voluntary reporting period, but starting in January 2020 is considered the educational and operations testing period, where we should really be trying to implement and put into place the clinical decision support software. Dr. McEnery is going to go into some of the detail of the challenges with the implementation and the time that it may take to get this rolling. January 2021 is when payment is at risk, and so this is important to have in place by then. And then in January of 2023 or 2024, we expect CMS to start identifying outliers. And when we say outliers, these are physicians who are ordering studies who may be getting repeated inappropriate use of imaging alerts, essentially, relative to their peers. So specifically, what is needed to be compliant with PAMA for this, and this is for all physicians and anyone providing advanced imaging services. So this is for both the technical component as well as the professional component or any global fees that are charged. For reimbursement to occur, the claim must include which clinical decision support software was consulted. 2, it must show if there was appropriateness use criteria adherence. So that can include if it was adhered, not adhered, or not applicable. And this does not preclude any reimbursement. It's not a stop to getting reimbursed for the study. It's just you need to be able to report whether or not appropriateness use was adhered or not. And then finally, the National Provider Identification or NPI number of the ordering provider must also be included. There have been a lot of criticisms for clinical decision support, and I just wanted to go through some of these. A lot of people have said that it will become time-consuming, particularly for those of you who are in an integrated health system who may have an electronic health record. The extra clicks and alert fatigue may be frustrating for physicians and ordering providers. But I will say that there is a potential IT solution so that CDS isn't necessarily triggered if the appropriate order is put in by the clinician. So it sort of runs in the background. The appropriateness use criteria would still be consulted, and as long as it's adhered to, then it won't cause an annoying trigger to the clinician. You could also, there have been anecdotal from those who have imaged or implemented clinical decision support that some of the calls back and forth between clinicians and radiologists to change studies or to recommend a different study or to recommend not a study, those have been reduced because of the implementation of this electronic system that automatically will trigger an alert to the clinician to either recommend a different study or not image at all. There have been some complaints that this is an added layer of requirement to order a study. And I just want to point out again that this is very different than prior authorization, and that there is no denial during the process. There's no hard stop with clinical decision support, even if the appropriateness criteria were not adhered to. Some others have said that this is costly to implement, and one must weigh the loss of revenues in 2021 if non-compliant, as well as the resources involved with the current system with the Radiology Benefits Manager program. As I've said before, that there are some private payers that have discussed potentially the use of clinical decision support as a way for circumventing the prior authorization or Radiology Benefits Manager system. The lack of a hard stop negates the benefit of the program, and this is just something that I want to highlight. I've done some work with Dr. Lincoln at Baylor where we targeted specific clinical indications such as low back pain and have seen improvement in the ordering of studies through targeted approaches. And I think it really requires the input from all stakeholders, including ordering providers, radiologists, and then hospital administration to help to improve appropriate utilization of imaging. And then finally, others have said that this isn't really integrated with MACRA and MIPS and that this is an additional burden for billing. And there is credit for use of CDS under the improvement activity in MIPS, as well as promoting interoperability within MIPS. And so there are some options to receive credit for utilizing clinical decision support in this way. And I will turn it back over to Dr. Lincoln.
Thank you, Dr. Chen, for that wonderful overview on clinical decision support. I'd like to now introduce Dr. Kevin McEnery, professor in the Department of Diagnostic Radiology, Division of Diagnostic Imaging at MD Anderson Cancer Center in Houston, and Director of Innovation and Imaging Informatics, also in the Department of Diagnostic Radiology at MD Anderson. Dr. McEnery has led the implementation of CDS at MD Anderson as the chair of Clinical Effectiveness and Evidence-Based Imaging Committee, which oversees the creation of evidence-based clinical imaging guidelines as part of MD Anderson's designation as a provider-led entity. Dr. McEnery?
Oh, welcome. Happy to participate in this. One of the things that in listening to the prior presentation, I think clinical decision support needs to be demystified in some respects, because I suspect most of the participants in this call are trying to figure out how this all applies to their institution and the decisions they can make. And so rather than talk about the law, just talk about decision support itself. The way decision support is currently implemented in most systems, and there are I'm trying to generalize as much as I can, because the clinical decision support mechanisms, which are effectively the products that are available to be purchased to implement, take somewhat different approaches, but all eventually get to the point of making a decision based upon the information that's provided by the ordering provider. So in this case, the order that the provider has entered is CT chest with contrast. And in the ordering process, the clinical history and the indication are then provided, in this case, lung cancer suspected, and initial staging. When it goes through the rules engine, which is the appropriate use criteria of rules engine, the CDS outcome for that is appropriate. One of the points that needs to be made is when implementing a system, it's not only the software that's being implemented, but is the rule set that's also going to be implemented that the rules engine is going to act upon. So in this case, the order is appropriate, the order goes through. Organizations will need to make a decision. I think it's a really easy one. In the final rule last year, the CMS said the clinician, if they're entering an appropriate order, does not need to be told that the order is appropriate. So essentially, if a clinician is entering an appropriate order, the system can be configured, and I would recommend should be configured, not to interrupt the workflow of the clinician. If the history is provided, the indication is provided, the system decides the order is appropriate, and the order goes into the EMR with no further interruption of the clinician. Conversely, in a situation as mentioned about low back pain, a history of clinician would like to order a lumbar spine MRI without contrast. The history is acute low back pain with normal x-rays, and the indication is 1 week duration. Well, most evidence shows that MRI in acute back pain is not indicated given its low yield, and most of the systems require a several month timeline of back pain, presuming the patient doesn't have a cancer history. And this exam would be raised inappropriate. At this point, the system would interrupt the clinician and explain the order is inappropriate, but the clinician can, in fact, put that order into the system and order the procedure as ordered. At that point, the provider will be identified as having entered an inappropriate order, and as was mentioned, sometime a year, 2 or 3 years from now, the specific date has not been set, outlying providers will be identified, approximately 5%, and they will need to contact CMS for all their ordering directly by a phone. So it's kind of a disincentive to be identified as an outlier provider. The third scenario, which is problematic in several ways, is going back to our person with lung cancer suspected wanting a chest CT, and then the indication, and I suspect nobody on the call has clinicians that do misspellings if they're entering indications, but in this case, the system would not be able to determine the indication because it doesn't understand that indication and would then return the AUC not applicable. And most systems at that point would not interrupt the clinician, and the clinician would have no idea that the information that they put in was not applicable. Now, the downside to this is potentially an inappropriate examination, but more so, CMS is going to be auditing sites, and they will look at clinical histories of lung cancer suspected, and if clinicians continually put misspellings or terms the system doesn't understand, there will be a high rate of AUC not applicable. CMS is explicitly in their priority clinical areas looking for high utilization of appropriate or inappropriate orders. They're not expecting to have no rules being fired. So this could also place an institution at jeopardy for further action by CMS, and that will probably be clarified in future rulemaking. So the value chain improvement we've been talking about, it is possible to implement CDS in a very minimal scope project, focusing only on the order, the decision support mechanism, and the codes that are necessary to fulfill the bill. You would meet the PAMA requirements, you would avoid adverse penalties, and arguably, the outcome would be fulfilling the scope and the intention of the requirements. But at MD Anderson, we've taken a somewhat different view of this in the value chain improvement. But if you look at the order entry process and the decision support process, it's the first basically node of an entire value chain of prior authorization that was mentioned. So if in fact you have a system where in that prior case the clinician misspelled or didn't provide information appropriately, the system would basically would not prior authorization, if you had an automated system, would essentially be negated and then defeats the purpose of the order entry. In terms of scheduling the patient, if the order is inappropriate or the order is deemed to be not appropriate by the radiologist, the patient could be told they need to reschedule the examination. The protocol that the radiologist picks for the examination could be incorrect based upon insufficient or inaccurate information. And the image acquisition could be impacted, the interpretation could be impacted, and finally the billing and results process could be impacted. So if you look at CDS as the ability to change the order entry process to provide accurate information to the value chain, it actually has the largest value for CDS, well beyond just meeting the mandate. Appropriate context throughout the value chain will lead to process improvement throughout the value chain, improve the patient experience, increase the value reporting, and it candidly will increase the clinical outcome probability for a given patient. So at MD Anderson, our content strategy is actually to place CDS in the context of the overall strategy of the institution to provide clinically effective care throughout the process. So at MD Anderson, we have clinical practice algorithms which are updated on a 2-year cycle. We've now integrated the active participation of domain-specific radiologists to update these protocols, specifically looking at CT, MR, nuclear medicine, PET, but as well as the entirety of the imaging cycle. And as per the requirement of a provider-led entity, this review is evidence-based. There's a process which we won't go into, but essentially literature has to be reviewed, best practices need to be reviewed, and then that supports the imaging that's provided in the algorithm. And then what happens after the entire algorithm is created, the imaging algorithm is abstracted to know that a chest CT with and without contrast is appropriate for certain indications. So it's not just the radiologist alone, it's a multidisciplinary team and working, in this case, a small cell lung carcinoma algorithm where the radiologist and the clinicians, the surgeons, the radiation oncologists discussed the imaging that was included in the algorithm and had evidence to support the imaging, and therefore we were able to develop appropriate use criteria around that algorithm in the clinical scenario of lung cancer imaging. One of the things about decision support that's interesting, getting back to structured and unstructured indications. Structured indications are essentially predefined words groupings, such as initial staging of lung cancer, such as abdominal pain, etc. And unstructured is essentially free text entry of text as far as the indication provided. In this study, which appeared in the Journal of American College of Radiology in 2017, when the provider entered clinical information, just the indications, they only had an AUC rating of approximately 25 to 28%. But after the radiologist actually looked at what the provider entered into the order entry system, as well as reviewed the chart of the patient, the AUC rating markedly improved. So the key takeaway for this is you want to optimize the CDS system to have as much clinical detail provided into the order to enable the value added process that we've been talking about. Now, CDS 1.0, there are systems out there that have implemented the system, and there's been some problems. And it really, in my opinion, the problems have revolved around the non-structured or free text entry of indications. A lot of institutions turn the systems on and now turn them off simply because there was such pushback from the clinicians as the system was interrupting their workflow. With this, there's just anecdotal reports of minimal impact in changing order entry patterns. There's been some success stories, no question about that, in use cases. The lumbar spine MRI for back pain is a particularly good example. And one of the things about the 1.0 systems is they were really, because of the timeline, aggressive timeline initially, the systems were essentially put into place and inserted into workflow. They weren't integrated into workflow. But there's a growing consensus amongst the not only radiologists but also the decision support vendors that structured indications are going to be necessary for CDS implementations. Effectively, it's mandatory. Now, that being said, with the advances in artificial intelligence and doing natural text processing, the absolute necessity of structured indications may be mitigated once artificial intelligence, natural language processing becomes more widespread. But today, the natural language processing systems are still not up to speed on getting the indications assessed. The other thing about clinical decision support, this is not just an IT project. This is a project that requires buy-in throughout the institution to understand what the processes are. At MD Anderson, I've had as many meetings with clinicians and administrators and radiologists as well, but also have met with billing cycle, rev cycle personnel, and also with the clinicians. And we do believe that this system, because it's integrated in essentially aligning with the clinical processes of the institution, is going to be successful. We have pilots in place. But the other thing that's interesting, even the work we've done, the system is still in silent mode. And the reason that is we're watching the interventions that we're doing. We're collecting data on what indications the clinicians are putting in and simulating what the outcome of the system will be for the clinicians. And we'll be turning the system on officially over the next several weeks. The other important thing about the silent mode is you get to see the performance characteristics of the system, and we've actually made some changes to the system and how it retrieves data from the electronic medical record to not impact the workflow of the clinician. But the key take-home point is that this is not just a radiology project. This is not just something that you're going to bolt onto the system. It really has to have buy-in across the institution. Not only in my opinion, the buy-in is not just to meet the PAMA regulations, but really it's to increase the value of imaging throughout an institution for the benefit of patients. The wider context of CDS, one size doesn't fit all. MD Anderson is a closed healthcare system. Although we do imaging from clinicians not affiliated with the institution, the great majority, over 99% of the imaging is done by clinicians employed by MD Anderson. And that system, everyone is using the same electronic medical record, the same order entry system, and so one system is necessary and only one set of training is necessary. I do believe that systems, and probably the MD Anderson is an outlier being such a closed system, but I suspect many on the call are in a situation where I call mixed practice system, where you have some providers that are employed by the institution and or are tied directly to the institution, but you have many physicians who are not directly aligned and may refer to several different hospitals. One of the good news is that there isn't a hospital in the United States that will be able to avoid this, unless you don't want to get paid for Medicare imaging. But essentially, clinicians can't say, well, I'm going to refer to St. Elsewhere General down the street because they don't make me do this. Well, the reality is that in order to get reimbursed by Medicare for services rendered, both the technical and professional fees, the systems need to be used. So in presuming most hospitals now, given the Affordable Care Act, or given the implementation of EMR systems, have EMR systems, they will need to have ways for people to access their decision support system outside of the hospital. One of the key things that needs to be known is if there's paper in your process, the paper will need to include a code issued by the clinical decision support systems in order to get reimbursed down the line. So paper can still be in the system, but it will involve the provider in their office to consult the system, whether they have access to the hospital's EMR, or another alternative which is being offered is a free access to systems to do the decision support, and then to acquire the billing codes that are going to be necessary to get reimbursed. I believe that the most complicated scenario is what I call unaffiliated provider, in the context of the freestanding family practitioner who only refers to a freestanding imaging center. It's an at-risk scenario, candidly. That provider is going to need to have the ability to enter orders. I suspect that entrepreneurs that are out there those imaging centers will be very motivated to make it very easy for them to and refer to their imaging center by providing a portal of some ilk to enter the order. But I do believe that's, in general, is the highest at-risk scenario, because it's, the provider, the independent provider doesn't, necessarily have the resources to implement one of these systems, and portals will need to be implemented. We can talk more about that during the Q&A session if there's an interest. Well, thank you.
Thank you, Dr. McEnery, for the details on clinical decision support. So we'll move on, and I'm sharing here some Imaging 3.0 resources. I see that many of you in the chat box, audience members, have been asking questions that have prompted the resources, and so some of them that are present, and you can click on them in that chat box, are the Value Chain Series, the CEO Suite Collection, CDS Special Section, and the case studies. So thank you to Drs. Melissa Chen and Dr. Kevin McEnery. I'd like to thank also the American Hospital Association for hosting this webinar. At this point in time, I'd like to now open the forum to questions. If you could put the questions in the chat box. I see that some of them have come through. We'll start off with the ones that have come. So for those of you in the audience who are thinking of some questions after this, please feel free to put them through the chat box. The first question that came through, Dr. McEnery, can you answer, there's a question from Ellen Gatner. Are you at liberty to say which third-party product you implemented at MD Anderson?
Yeah, we're implementing the Medicalis product, which is now Siemens, owned by Siemens.
Okay. And Dr. Melissa Chen, could you answer the question from Jennifer Arango regarding CDS, whether it cancels the need for prior authorization of imaging studies?
So for Medicare, I think this obviates the need for a prior authorization, but this is only for Medicare Part B payments. And then, as I alluded to before, I believe that there are health systems that are in discussions, or that, there have been murmurs from private payers saying that the CDS could be something that could be applied to patients, to their patients as well. It's not nothing official, but this is something that's sort of being discussed, and so I think it's an advantage for those hospital systems that can implement this pretty efficiently.
Great. There is a question about whether the slides will be sent out, and I'll answer that. These slides will be sent out by the end of the week to all those who are registered attendees. Another question that's come up is Barbara Mullick. It has been advised that CMS will G-codes and modifiers to identify the CDS system and appropriateness. Can you direct to where CMS has identified this? I'll leave this to either of you to answer.
This is Doc. I can answer that question. There is going to be a re-release. So short answer is that they haven't specified the codes, but there is going to be a release of what's called the physician fee schedule rule. It should be any day now. Historically, it should have been last week, but CMS most certainly will then have great detail of what those codes are and what the process for submitting them are to their system.
Okay, great. And there was a question about practitioners who don't have electronic healthcare records. There is a resource that's been provided by Becky Haynes. If you can just click, it's an access there for Care Select Imaging Open Access link, so you can get to that if you don't have electronic health record at your place of practice. Another question that came through is, how is MD Anderson managing emergent exceptions to use of consultation?
I can take that. Right now, as mentioned, the system is in silent mode, so we haven't experienced the emergent exceptions to use of consultation. But one of the points is that I expect that there'll be very few times when decision support isn't necessarily be consulted, because it's going to be integrated into the order entry system. So by a clinician entering the information for the study, they in fact have fulfilled their requirements for clinical decision support. So there isn't a way to bypass it. And again, if the order entry screen comes up as the study's inappropriate, the clinician can still do that order or then easily select the appropriate order. I really don't believe that that's going to be a huge problem in the sense of how we're integrating the system into our order entry system. Even in an emergent situation, an order has to be entered. The other point too is, yes, it's the emergency room, and it applies to emergency room scenarios where probably most of your emergent situations happen. But even in that scenario, even for an emergent study, an order has to be placed into the system, so decision support will be in the loop.
Great. Okay, another question came in from Don Casey. What is your opinion regarding radiologists who are willing to participate directly in shared decision-making discussions with patients? For example, incidental ovarian cysts not requiring more extensive imaging follow-up. I don't know which one of you guys want to answer that question. Kevin?
I guess, I'm trying to understand the question. I think, at our institution, we do have an ovarian cyst sort of algorithm. A lot of these, in our institution, when studies are ordered by clinicians, they usually have a discussion with them anyway about why they may be or may not be ordering a study, and then even results are oftentimes conveyed by the ordering provider, whether it be the oncologist or the surgeon. And so usually those discussions about appropriateness of follow-up is usually happening with the clinicians. It's rare that the decisions or those results are being conveyed by a radiologist. I think lung cancer screening is a little bit of a different scenario, but for ovarian cysts, that's something that a lot of times our clinicians are sort of walking the patients through. I know, anecdotally, I know that, for example, at MGH, where they've had the clinical decision support as a part of their system for a while, I forgot what they name it, but apparently patients have come to know the system very well. And so a lot of times when they go into the primary care provider's office and they say, I have this problem, I think I need imaging for this, a lot of times they know now that the primary care provider is going to say, well, let's check with the system and see what it says about the appropriateness of the study. So I think once it becomes integrated, it can be something that can change culture about how patients are educated regarding the appropriateness use. Also, as well, I know Becky Haynes will be remiss if I don't point out that there is appropriateness use criteria that have been translated for patients that are patient-friendly that the JACR has put out on multiple different appropriateness use criteria. And so it is a resource for clinicians, radiologists, that if they want to use those, that would be a resource for patients as well.
Great. There's another question that came up. Can you discuss which clinical staff, and the clinical staff was written in quotes, are considered acceptable in ordering studies using the CDS?
Well, each institution has to decide that. So it's at MD Anderson, it's being defined as those providers based on their scope of practice that are allowed to enter orders into the system. To get it to have an imaging order placed into the system, it cannot be placed by an front office personnel. It has to be placed by an ordering provider. That could be the physician, an advanced practice nurse who has ordering privileges, or a physician assistant. Each organization will need to decide that, but and that's how MD Anderson has decided it.
There was a uploaded by Chris Hobson with a document of the 2019 final rule, which actually goes into detail about clinical staff for those of you who would like to reference that further. Another question came up, will your techs be contacting provider to change orders if the provider is not using the appropriate testing?
That's a really good question, in the sense that, you know, I would suspect that if an inappropriate order comes in, in our organization, the radiologist or physician's assistant review every order to protocol it. And, you know, I would say if a study is grossly inappropriate for the patient's clinical presentation, I do believe that it's in the best interest of the entire health delivery process for a clinician to be contacted to say, hey, there's actually a better way to do this. I would hope, though, that's the exception and not the rule. I do also think that organizations, again, this gets back to EMR vendors, will have tools to identify what's considered outliers under the rule, and be able to track which physicians are changing orders from inappropriate orders to appropriate orders, as well as putting in what's quote-unquote inappropriate orders, regardless of what the decision support is. So there will be tools to monitor this as well on a global basis, just so clinicians won't be surprised when they're identified potentially as an outlier to the process, if that answers the question.
Okay, I'm looking to see if there are any other questions that are coming through from our audience. So when does the outlier status begin? January 1st, 2020 or January 1st, 2021? I'll ask Dr. Chen or Dr. McEnery if either of you want to answer this.
So I think that we're still waiting for clarification from CMS, but I think the PAMA legislation said that by 2023, 2024 is when we would expect for the outlier policy to take place. But I think that there would be more clarification in future rulemaking. But the 2021 is when payment is at risk. If you do not consult clinical decision support, that's the sort of the more present deadline that we need to ensure that we are compliant with.
I would agree. The earliest that would be was 2023, based on prior commenting, but I'm clearly CMS will be clarifying that potentially, like I said, in the upcoming rulemaking process that's about to kick off.
Great. Dr. Chen, I have a question for you. Do you talk to patients when you see them in your practice as a radiologist?
Yeah, so I saw that later after I was talking, and if patients do request to speak to a radiologist, I'm available to speak to patients. In fact, we do have a clinic where we do ultrasound biopsies and we discuss results with patients, and I go over imaging findings with them. And so I think if patients request it, that's something that I'm willing and happy to do.
Great. Are there any more questions?
Christie, I see, or Dr. Lincoln, I see that there is one other question about discussing experience with orders coming from providers working outside of the EHR healthcare system. And I think Dr. McEnery alluded to it. He might have something to add, but I think one of the solutions that people have discussed was having providers basically use portals that are available for free online to consult for example, the ACR has appropriateness criteria that has a portal for free that you can consult, and it would give you a number or some sort of code back showing that you consulted it, and would also give you the output as to whether or not it was appropriate or not appropriate. And that could be something that ordering providers could use when placing the order. It is a little bit more cumbersome for them, admittedly, but that's sort of going to be the new life, I think. And I don't know if Dr. McEnery has other suggestions.
Yeah, there's a subtlety in this, which I think there is not a requirement in the law that the ordering provider use the system that's provided by the imaging provider. So the ordering provider does not, if the ordering provider wants to refer to hospital A, they can use the free portal to do that, even though it's not directly supported by Hospital A, because the codes that are going to be submitted on the bill are only refer to the clinical decision support mechanism, what rule fired, and what was the outcome. It does not have any bearing on where or what system or what hospital system provided the system to the provider. So there is not a lock-in. So any institution that thinks that they can tell their clinicians, we're only going to do imaging that's certified by our system, is probably going to set themselves up for some serious failure.
Great. There's also a example of, I think Dr. Chen mentioned that there's a case study that was performed at MGH where they're building a patient consultation clinic where radiologists develop a virtual consult program. That link here is provided in the chat box for those of you who want to see, that radiologists are in action and actually speaking to patients. And for those of you who want more details about consultation by ordering providers, there is another resource that was uploaded to the chat box referred to as AUC and clinical staff. It's a PDF that you can review as well, again, to review how consultation by ordering providers, or the details of it. We're welcoming more questions from the audience as we still have more time.
All right. It doesn't look like we have any more questions coming in. I just want to thank everyone today for their attendance, and to the American College of Radiology, our speakers, for this wonderful presentation. As a reminder, we will have the slides and a recording available on our website by the end of this week. And our website is aha.org/physicians. And I believe we'll be following up with you guys as well to share those slides. With that, as there are no more questions, this concludes today's call. Thank you, everyone.